Well, welcome back, everybody. Hope you had a good few sessions as you were roaming around to different rooms for the Innovation Bazaar. So now we're going to transition to our final segment of the day. We are going to focus this session on the evidence findings report. So hopefully you all have had access to it. Perhaps you've read through it. Whether you have or not, we have the expert in that report, the author of that report, Yalda Jabalpur, who's going to present who's going to be presenting about the report, her findings, and then we're going to invite up to the stage two additional experts to share their perspectives and implications of the evidence report. We have Sienna Ruggieri and also Margaretta Brandt. So we'll first have, and Daniel McCarter. Sorry, Daniel, if you're out there. So I would like to invite Yalda Jabalpur to the stage to present her findings from the evidence report. Please.
Hello, everyone. My name is Yalda Jabalpur. I'm a family physician and director of the American Academy of Family Physicians Robert Graham Center. And I'll also be your moderator for this session, Exploring Usual Source of Care. Each year, the PCC produces an in-depth report that analyzes a timely primary care topic and provides relevant data and evidence. This is the 11th annual evidence-based report produced by the PCC and the 4th one produced in partnership with the AAFP's Robert Graham Center. This year's report has been made possible by the AAFP Foundation, the American Board of Medical Specialties, the American Board of Internal Medicine Foundation, and the American Academy of PAs Foundation. The 2022 PCC evidence report is focused on a key metric that is at the heart of primary care, and that is usual source of care, or the relationship between a patient and a primary care clinician. And unfortunately, as this report shows, the heart of primary care is stressed. Rates of usual source of care continue to fall, are far worse for people of color, and there have been troubling declines for more medically vulnerable populations, including those covered by Medicare and Medicaid. This report, which also includes usual source of care rates by state, helps draw attention to a problem that we collectively need to fix to get our nation back to better health. We know we can do better, and we must. I'll provide a brief overview of the report, and then we'll talk about it with a stellar lineup of experts. We know from previous literature the importance of having a usual source of care and how important that is to achieving better health outcomes. Unfortunately, in this year's report, we found that the percentage of individuals in the United States who report having a usual source of care is falling. Specifically, using the Medical Expenditure Panel survey from 2000 to 2022, we found that nationally only 75% of people report having a usual source of care in 2022. And this is down from 84% just 10 years ago. The drop in percentage of people identifying a usual source of care is not uniform in all populations, though. There are geographic and demographic level factors that seem to have some influence. We explored the geographic differences using the Behavioral Health Risk Factor Surveillance System, or BREFIS data, which also asks about usual source of care and has publicly available data available for all 50 states. Using this data set, we observed state differences in reporting of usual source of care. In the upper Northeast and pockets of the Midwest, the percent of people who reported a usual source of care was highest, and for many states in the Southeast and Southwest, it is the lowest. The question is why? And although there are likely many factors influencing the uptake of usual source of care in a state, we wanted to explore the possibility that primary care supply may have something to do with it. Using the Area Health Resource File for 2019, we were able to calculate primary care physician density for each state. For some states, we found that the relationship between usual source of care uptake and primary care physician density did matter, meaning that when PCP density was higher, usual source uptake was higher as well. But there are states that are outliers. For example, in Kentucky, we found a low PCP density, but high percentage of people reporting a usual source of care. And in Alaska, Minnesota, and Colorado, we found the opposite, a high PCP density, but a low percentage of people reporting a usual source of care. But it wasn't only geographic level factors that influenced the findings. Individual demographic factors also mattered. So looking at the MEPS data again, we found that those under 18 had the highest odds of having a usual source of care. When looking at the data slightly differently and examining instead the percent of people without a usual source of care, we found that although the percentage of people above age 65 without a usual source of care was relatively low, it's not all good news. Because in this age group, there was actually a 60% increase in those without a usual source of care between 2014 and 2019, which is extremely concerning. People in the 18 to 34 age group were most likely not to have a usual source of care. And again, the percentage of that population reporting no usual source of care also increased between 2014 and 2019. Race also matters. For Black and Hispanic individuals, there was a lower odds of having a usual source of care compared to white individuals. Hispanic individuals had a 66% higher rate of reporting no usual source of care compared to white individuals, and non-Hispanic Black individuals had a 37% higher rate of reporting no usual source of care compared to white individuals. This gap exacerbates racial health disparities that already exist, since we know from previous literature the importance of having that regular and continuous relationship with a clinician to good health outcomes. We also found that insurance matters. Between the 2015 data and the 2020 data, people reporting a usual source of care fell for all insurance types, which is very concerning, particularly for the Medicare and Medicaid population, who tend to be more medically vulnerable. In both years for the insurance cohort, Medicare did have the highest percentage of people reporting a usual source of care, and commercial insurance the lowest. Not unexpected, those who were uninsured had the lowest levels of reporting a usual source of care, with only 38% of the uninsured reporting having that regular connection in 2020. Overall, these results are concerning, particularly for certain age groups, racial and ethnic groups, and for the uninsured. Why is this happening, and what can we do to solve the problem of declining usual source of care in the United States? That is what the next 40 minutes or so will cover, and to help us do that, we have 3 amazing panelists. So I'd like to invite them all up to the stage right now. We have Sienna Ruggieri, Margaretta Brandt, and Dr. Dan McCarter. Thank you. So Sienna, we'll start with you. Sienna is a policy analyst for the Center for Consumer Engagement and Health Innovation at Community Catalyst. In her role, she works to ensure that public programs, including Medicare and Medicaid, better address the needs of consumers, particularly those with the most complex needs. Her work focuses on people dually enrolled in Medicare and Medicaid, family caregivers, and advancing opportunities to address social determinants of health and promote health equity. Before joining Community Catalyst, Sienna worked as a government relations association at Network Lobby for Catholic Social Justice with a portfolio that included healthcare, housing, labor, and paid leave for federal policy. Sienna graduated from Regis University with a Bachelor of Arts in Politics and a minor in Peace and Justice Studies. So Sienna is going to tell us a little bit about what Community Catalyst has been doing around usual source of care and their recent findings.
Thanks for the warm introduction, Yalda. So I'll talk a bit about our report. It's called the State of Person-Centered Care. And this report details the state of person-centered care and highlights the fact that 1/3 of people 50 and older report rarely or never having their care preferences taken into account by their clinicians. And that includes more people of color and lower income individuals saying so. And this report provides the first ever look at how person-centered care models are working or not for older adults. So in this study, we compared data from the health and retirement study, and we found that whether older adults' preferences were taken into account by healthcare providers is heavily dependent on 3 factors, and that's race, insurance, and income level. To dive into some of those details, Black and Hispanic older adults are more likely to report never having their health preferences considered versus white adults. For Hispanic adults, that's 24% have never had their needs and preferences taken into consideration in their primary care. And these disparities appear to be widening over time. In terms of income, individuals who report their clinicians never account for their preferences are twice as likely to have incomes below the federal poverty level compared to those who report clinicians always taking their preferences into account. And then finally, insurance. Higher numbers of people on Medicaid report clinicians sometimes or never consider their care preferences. So we also took a look at the probability as well as the significance level for the impact of having specific socio-demographic characteristics on the probability of having one's preferences for care considered over time. And those characteristics that were associated with having care preferences considered over time were being a Medicare beneficiary as opposed to Medicaid or dually eligible, and having a usual source of care. So having a usual source of care at baseline was associated with 49% lower odds of reporting that the system never took care preferences into account. So clearly there's a relationship there. And we also saw the negative health impacts that occur when someone does not have a usual source of care. So one of the most prominent examples in this report is that when preferences were ignored, older adults were more likely to forgo medical care, including preventative care, and report lower satisfaction with their health care. There's also the presence of higher risk biomarkers and poor reported health. So when controlling for demographic, financial, and health characteristics, those reporting a never rating in terms of having their needs and preferences considered had higher odds of uncontrolled blood sugar and hypertension. And in line with our previous findings, older adults of color and those with lower incomes had higher odds of high-risk biomarkers. As expected, those with a usual source of care were less likely to have these high-risk biomarkers. And also, higher proportions of people who only sometimes or never have their preferences taken into consideration were more likely to report their health as fair or poor, had a greater likelihood of reporting depression, and were more likely to be smokers. A consistent finding across our analyses was the association of having a usual source of care with a range of positive outcomes. So having a usual source of care made it more likely that care preferences were considered. Scores that predicted higher associated healthcare costs would be lower. And there would be lower likelihood of high-risk biomarkers, and there would be higher levels of preventative care and care utilization. There's also evidence in our findings that having a usual source of care increases the chance of people of color experiencing person-centered care that takes their preferences into consideration. So that having that usual source of care weakens the associations between being a person of color and reporting that one's care preferences were never considered. So putting that another way, having a usual source of care can decrease the likelihood of never having care preferences considered among older people of color. And the same is true for people with lower incomes. So clearly, having a usual source of care can decrease the likelihood of never having care preferences taken into account among those with lower incomes and those who live in poverty. So, all that to say, a usual source of care combined with whole person care seem to not only increase access to care, but also the quality and the equity of care. So taken together with the race and ethnicity findings I detailed, these findings highlight the important role of having a usual source of care in achieving a person-centered healthcare system. Thanks.
Thank you. Thank you, Sienna. Really interesting findings and parallel really well with our report, too. Next, I want to quickly introduce Margaretta Brandt. Margaretta currently works as the Quality Improvement Manager for Covered California, where she leads the quality improvement team that collaborates with health plans to improve healthcare quality and implement delivery systems and payment reform. Margaretta was previously a senior quality improvement specialist leading Covered California's efforts to improve quality and reform the healthcare delivery system through promotion of advanced primary care, integrated delivery systems, and accountable care organizations, effective behavioral health, and provider networks based on value. Prior to Covered California, Margaretta worked at a nonprofit coalition of public and private healthcare providers and community organizations. As the program analyst for the coalition, she facilitated a collaborative quality improvement initiative for 12 local safety net clinics. Margaretta holds an MPH in Health Policy and Management from the University of California, Berkeley, and a BS in Health Sciences from the University of California, Santa Cruz. And she's going to talk to us about what Covered California is doing to strengthen usual source of care.
Yes, good afternoon, everyone. Thank you for having me. I'm really excited to share what Covered California has been working on in terms of having a usual source of care for all of our members in the context of our overall work to improve quality and reduce health disparities. So Covered California is the California Health Insurance Exchange, and we work to ensure that all eligible Californians have affordable coverage options by creating an attractive, competitive marketplace and supporting consumers in choosing the best plan for them. And our mission is to increase the number of insured Californians, improve healthcare quality, lower costs, and reduce health disparities. So I work on the team that works to implement those later three parts of our mission. And Covered California has recently really strengthened our health plan contract requirements related to quality and equity and reducing health disparities. And we've implemented several new programs that start in 2023. I'll share a little bit about one of those programs and then get into our primary care work. So one of those programs is the Quality Transformation Initiative, where we are setting holding plans accountable for improving quality on 4 measures by setting a % of their premium at risk for performance on these measures. We're starting with 0.8% at risk and eventually will increase up to a maximum of 4% at risk for improvement for performance on these measures compared to national benchmarks. And that really ties into our focus on primary care. And so since inception, Covered California has really built its health plan contract requirements around a foundation of advanced primary care. And we believe that advanced primary care is the foundation to a high-functioning healthcare system, and that we can't reach our goals for quality and health equity and reducing disparities without supporting primary care providers. And so we have focused our primary care requirements in our contract on 3 things: matching, measures, and money. And so starting with matching, this is our usual source of care requirement. So starting in 2017, we required health plans to match all of their members, whether they were in an HMO, a PPO, an EPO, to a primary care provider upon enrollment. So we've had that contract requirement in place since 2017, and happy to report that since then, since about 2018 on, 99% of Covered California members are matched with a PCP. That's self-reported by the plans. And we really want this requirement to reinforce the concept of primary care providers as a resource, as a primary source of healthcare. Coordination and support. We're not promoting a gatekeeper model in PPOs, EPOs. That's not our goal. It's really for primary care providers to be a resource and the foundation of everything else that we're trying to achieve. And so when we first implemented this, it took a lot of work from our health plans to change their IT systems, to really educate their members about why we were implementing this, and we worked very much hand in hand with our health plans to do this. Lots of call center support, helping our call center when folks called in to explain the context and why we were implementing this. So, that's our matching requirement. And then in addition to that, we also encourage the use of primary care through standard plan benefit design. So preventive care is free, under our, or no cost share under our benefit design. And then primary care visits are not subject to deductible for most plan types through Cover California. And our next step in terms of the matching is to really look at members who are actively choosing a primary care provider versus those who are passively being assigned a primary care provider, and try to look at this through whether that means that members are more engaged when they actively choose, or does this impact quality. And then we also want to look at this by demographic factors based on what we're learning from the PCC evidence report and other evidence. And I'll quickly run through measures and money. So beginning in 2022, we required our plans to implement an advanced primary care measure set with their primary care providers to measure the performance of primary care practices in their networks. And we're working collaboratively across California with public purchasers, with the California Quality Collaborative, with the Integrated Healthcare Association to implement this measure set. And we really believe that, by identifying primary care practices who are providing that high-quality primary care, we can then determine the concentration of these practices in our health plans, and then work with our health plans about, if practices are not performing very well, how can we enhance technical assistance or look at their payment models, and then what can we learn from those high-performing primary care practices. So our goal is to really understand the network and the performance, and then work to improve performance overall. And then for money, for several years, Cover California has required health plans to increasingly pay primary care providers using shared savings and population-based payment models. We use the HCP LAN category 3 and 4. And then we also recently required our plans to report how they are how much they're spending on primary care, so their primary care spend as a % of their overall budget. So we're seeing kind of slow but steady progress on transitioning towards value-based payment over the past few years. And then, we did sponsor a study in California. There have been many studies about primary care spend, and we found in California that higher primary care spend is associated with better outcomes. So we're looking, based on that report, and then based on what our health plans are going to report to us soon, if we maybe set a target or a floor for primary care spend for our health plans. So we really see our PCP matching requirements, having that usual source of care as a foundation for our other requirements related to how we're measuring the performance of primary care practices and how we're paying primary care practices differently for high quality care. Thank you.
Thank you. And finally, last but not least, I'd like to introduce Dr. Daniel McCarter. Dr. McCarter is the National Director of Primary Care Advancement for ChenMed. He joined ChenMed in 2017 after serving on full-time faculty at the University of Virginia for 27 years. He continues to hold a teaching appointment in the Department of Family Medicine at the University of Virginia School of Medicine. And he's going to talk to us a little bit about what ChenMed is doing around improving usual source of care and patient contact.
Sure. And so one of the presentations that I sometimes do for residents is titled The Primary Care Revolution, Dispatches from the Front. So I think we're doing a lot of what you all are talking about. We are a 36-year-old startup. It's a physician-owned, physician-led, transformative primary care model. We're now in 15 states with 105 offices. We provide a VIP level of service for the old, the poor, and the sick. We cap panels at 450 patients for our PCPs. Our model is to see each patient once a month, and then the sicker patients to see them more frequently. Our average patient is 72 years old. Our average patient has 5 or more chronic medical conditions. 30% of our patients are dual eligible. 70% of our patients are minority. We specifically go into areas where there are high density, low income, underserved seniors. Part of our model is we provide on-site dispensing of generic medications. We provide transportation to and from the office. Prior to COVID, we had our own vans that we would drive around to get people. During COVID, we had to switch to Uber and Lyft, and that's probably the direction we're going to continue to go that way. Every patient gets their doctor's cell phone number on the first visit, and we encourage them to call their doctor first. And then if their doctor is not available, then they can call the office at any time. It goes through a nurse triage line, and then we'll go to the PCP on call. So our doctors aren't on call 24 hours a day. I mean, I do sleep at night, but my patients do page me on a pretty regular basis. So, you know, the results we get from that, because our model is obviously quite a bit more expensive, the results we get from that is we get 30 to 50% fewer hospitalizations. It depends whether you risk adjust or not. We spend a lot of time on the HCC risk adjustment, but we get 30% fewer hospitalizations if we don't risk adjust. We get about a third lower spend because of that. We have about a third fewer ED visits, and we get about a 40% increase in preventive medication use. And then we get top decile patient satisfaction results, and we do very well with quality measures as well. So a lot of it, in the populations we serve, they haven't been cared for. So part of it's how do you build that relationship? I mean, I can remember talking to one of my patients about COVID vaccine hesitancy. And so we do, when our new doctors start, they go through 4 weeks of orientation. Part of that is a very in-depth training program in motivational interviewing. So, you know, my patient didn't want to take the COVID vaccine, and so we were talking, and I asked her what her concerns were, and she was talking about safety, and I said, well, can I share some information? She said, sure, and I said, well, I was sure the government had expedited all of the work, but they hadn't, but they had cut the red tape, so they got through it faster. And she just looked at me and she said, Dr. Dan, you're not expecting a black woman to trust the government, are you? And I'm like, good point. So now, you know, we had to have another conversation, and it took a few months, but she's fully vaccinated now. But it wasn't, I didn't force it at the time. So part of that is taking people where they're at and trusting them there. So I will say often that our model is simple, but it's not easy. And so that is the long and the short of it. I'm happy to answer any questions, and
Great. I could talk all day about it. Thank you. And just a reminder, if you guys do have any questions, put them in Slido. We're seeing them come up here. I wanted to ask you all a few questions before we got to the audience questions. So we hear from patients a lot. You know, we do this research that shows usual source of care is so important, but it's declining, and we want to increase that usual source of care. But we hear from patients a lot that they would love to have a primary care provider that they could get into, but when they call to make an appointment as a first-time patient, it's a 6-7 month wait, and that's why they don't have a usual source of care. So can you talk a little bit about how each of your organizations is maybe addressing or trying to study this tension between access and an ongoing relationship with a provider? And whoever wants to start first can go for it.
I can jump in, sure. So there's kind of a few ways, and you know, we're a little bit removed. Our work is through the health plans, so we're kind of working with the health plans to monitor how they're measuring access. So, you know, one is we require NCQA accreditation, and then we also require NCQA health equity accreditation, and a lot of those requirements tie back to access, monitoring access, cultural competency of providers, things like that. You know, we also really rely on our state regulators and monitoring the access requirements that our state regulators have and how our health plans are complying with those. And then we're also looking at kind of telehealth and the interaction of telehealth and how our members are using telehealth. So we require our health plans to report how they are integrating telehealth vendor services with in-person, you know, primary care services or in-person network-based services. So we're really looking to our health plans to kind of integrate across telehealth, convenient care and primary care, and to really connect the docs for consumers who may be seeking telehealth or convenient care, and connect that back to their primary care provider.
I can just speak to the disability intersection here. We've done a lot of qualitative research with dually eligible individuals, and there's a growing body of research about this. There's a recent article in Health Affairs that I'd point to about this, that primary care providers were found to have an explicit negative bias towards people with disabilities, and that's something we hear from folks in the field often, that literally they can't find a physician whose office is accessible. In terms of wheelchair accessibility or really basic access, things like that. But even beyond that, I know someone asked a question about transportation access. Absolutely, all of those little barriers add up to a make or break, especially for someone who has multiple chronic conditions. And I'm sure everyone in this room knows how challenging it is to get in to see your PCP when you're working. So you could imagine how hard it is when you're seeing multiple specialists and have multiple appointments stacked up, and some really immediate needs. So I think that we really draw attention to just those basic access issues can really make or break this. And it's something that we've seen start to be addressed by care coordination as well. So we really encourage utilizing that as a resource, and we're investigating more ways that care coordination can be improved, and also how can we connect more people to those resources, because a lot of folks who are navigating this aren't aware that there's someone out there who could help them navigate these waters.
Yeah, and I think the issue we have is, again, getting patients to sign up with us, because we are part of Medicare Advantage. So they have to choose a plan that we have a contract with, and then they have to sign up with us. And then what we're struggling with every year, if everybody has seen the sort of gold rush and Medicare Advantage and all of the commercials that are out there, and William Shatner calling me on the phone telling me I need to sign up for a different Medicare Advantage plan. So we have people that help make sure that they're able to look at what plans they have and help them choose the one, without telling them which plan to choose. But what we do want them to know is, if they're picking a plan that we don't have a contract with, they know they're going to lose access to us. They usually don't want to do that, but we want to make sure that that's a conscious decision on their part if they're going to choose to do that.
We have a few minutes left. I see some questions here that I do want to address. And Margarita, maybe this one is for you. How have you evaluated match and actual creation or maintenance of a usual source of care? And do you know how the patients feel about getting matched?
Sure. So a few things. So we, we have started in our initial years with plans self-reporting how many members were matched upon enrollment. And then we are now, as we have stood up, we now have a centralized claims and encounter database where all of our health plans are submitting data to us. So we're now looking at the claims and encounter database and like the PCP matching assignment through that. So kind of checking the work of our health plans and what they've been sharing with us for the past few years. And then in terms of how patients feel about getting matched, initially there was, a little bit of pushback. Especially as we work to first implement this program. But it's been, 5-6 years now, and we have gotten like very minimal pushback, and we're constantly kind of working to promote primary care both through Cover California's, social media and advertising and things like that, and also through our work with the health plans and how they're educating members when they first enroll what it means to be matched with a primary care provider in a PPO or an EPO, and how it's really intended to be as a resource and a source of care coordination, not intended to prevent them from going to see a specialist if they want to in that plan model. So we're still working on our evaluation, but that's what we've learned so far.
Excellent. So a couple questions here are coming up around the theme of external factors that are maybe competing. So for example, mergers of clinics that are combining forces, or with large health systems, incentives for acute services to be diverted. You guys have any thoughts about that and how that plays into usual source of care?
Well, and I'm maybe drawing from past experience. I think mergers, if you're treating primary care, if you're in the fee-for-service world and you're getting paid for doing services and it's RVU-based, primary care is a loss leader. It's the milk in the back of the store. And the more mergers that occur among large health systems, the more likely they are to reduce the expenditure on that milk in the back of the store. Because once they get people into the model, it works that way. And I think we have to go to risk-bearing, outcome-based models. I think primary care has to step up and lead that going forward. As far as overcoming competing incentives, the way I did is I left the fee-for-service world and went to risk-managed care. I couldn't think of a way to do it. I've said often when I was working with an ACO at a large health system, I felt like my marching orders were save money, but don't leave any hospital beds empty. And the problem is, if we're going to save money in healthcare, we're going to have to keep people healthier and out of the hospital, because that's where the money's spent. So I don't have an answer of how to do it in that way. The way I did it is I changed models completely, but I'm not saying everybody can do that.
Anything to add there?
Yeah, this I think connects to the question that was asked about going into the community as well, because we know, in broad strokes, it's kind of difficult to ascertain what exactly those external factors are, but when you really break it down by neighborhood, you can find primary care deserts. To use DC as a specific example, wards 4 and 7 have about half the primary care physicians that are needed for the populations of those wards. So just those things don't show up kind of in the broader strokes of the data. So I think it's really important to, we really emphasize partnering with community-based organizations that do have that trust and engaging directly with people in those communities and asking precisely, what are those factors? Like in your day-to-day, what is the barrier to getting to see your primary care physician? So I think there's a lot to investigate as we know these really disturbing trends are happening, really emphasizing qualitative research and working with community partners who already have that level of trust.
Well, thank you all for joining us up here, and thank you all for being in the audience, and a special thanks to Sienna and Dan, who both stepped in last minute because a couple of our panelists had medical emergencies. So thank you very much. Thanks.